Hello, everybody. This is Erica Spicer Mason with Becker's Healthcare. Thank you so much for joining us for today's webinar, where we will cover why health plans are missing one of their most costly surgical care categories. But before we get into the conversation, I'm going to walk us all through just a few quick housekeeping instructions. First, we will start today's webinar with a presentation, and we'll have time at the end of the hour for a question and answer session with the audience. You can submit any questions that you have throughout the webinar by typing those into the Q&A box that you see on your screen. Today's session is being recorded and it will be available after today's event, and you can use the same link that you used to log into this session to access that recording. And finally, if at any time you have issues with the audio or visuals for this presentation, just try refreshing your browser, and you can also submit technical questions into that same Q&A box. We are here to help. So without further ado, I'd love to welcome and introduce the two lovely speakers we have with us today. So we have with us Kathy Hartman, who is the Chief Healthcare Solutions Officer at Paradigm, where she leads healthcare strategy and product innovation. Kathy brings more than 25 years of experience across digital health, payer strategy, and product leadership, including leadership roles at Amwell, Blue Cross Blue Shield of Massachusetts, and Health Dialogue. And we also have Nicola Merriman, the Senior Vice President of Healthcare Solutions at Paradigm, where she leads product operations and analytics for Paradigm's solutions business. For Paradigm's healthcare solutions business. Nicola brings 20 plus years leading solution strategy and successful product launches, scaling to support growth and innovating value-based care methods at organizations including Teladoc Health, Blue Cross Blue Shield of Massachusetts, and Bristol Myers Squibb. Kathy, Nicola, thank you both again so much for being here today. Great to have your expertise on the line. And before we get into that first discussion question, I wanted to just give the audience a little refresher on what we'll be talking about today. So today we're primarily going to explore why most surgical utilization management strategies that health plans are using right now tend to intervene too late, and why a holistic approach can help to ensure that health plans aren't leaving savings on the table. So within that discussion, we're going to touch on why preference-sensitive surgery is a hidden driver of surgical spend. We'll talk about how upstream shared decision support reduces inappropriate procedures and downstream complications. We'll talk about how two complementary strategies can deliver $5,000 plus in annual savings per member. And lastly, we'll also touch on key findings from a matched cohort study across Medicare and commercial populations. So without further ado, let's go ahead and dive right in. Kathy, I'm going to send this first question over to you. We know that health plans are under immense pressure to bring total cost of care down. So I'd love to know how surgical spend drives total cost of care, and why is it critical for health plans to rethink how they're currently managing their surgical spend?
Sure. Thanks, Erica. That's starting off with a great question. So for health plans, surgical spend is one of the largest and fastest growing components of their total cost of care, but the surgery itself is often only part of the financial impact. So really thinking about these surgical spend categories as an episode of care that might include pre-op imaging, post-acute care, could lead to complications, which can lead to other services like readmissions. So historically, health plans have focused on approaches like prior auth, network steerage, which ultimately assumes that the surgery is going to happen. But there's a big opportunity upstream for members to understand if the surgery should happen in the first place and for them to make that choice. So many of the high volume surgeries that are in this category of spend are actually preference sensitive, meaning the best treatment actually depends on the member's symptoms, their risks, and their personal goals. And there are generally two or more non-surgical treatment alternatives that could be considered. So examples are joint replacement, spinal surgery, bariatric surgery, etc. And these preference-sensitive surgeries drive about 30% of total medical spend for payers. And it's often a hidden cost for them because these categories cut across specialties and aren't generally represented in one line item. But even more concerning is that up to 30% of these preference-sensitive procedures are medically inappropriate, and about 20% of all surgeries can result in clinical complications that can drive downstream, utilization, like additional ER visits and readmissions. So it's really important to ensure that members understand their alternatives to surgery and feel empowered to, make the decision that best meets their needs in partnership with their provider. And that's how we think about this surgical spend category.
Yeah, really illuminating, Kathy. I appreciate you sharing some of these important data points right off the bat and really breaking down what you're seeing at Paradigm. Next up, I want to go over to Nicola to talk a little bit more about specifically what plans are doing right now to control surgical spend. We're seeing some high numbers here that Kathy has shared. So Nicola, what are health plans doing right now to control that spend, and where are those strategies breaking down, if at all?
Yeah, absolutely. So today, most plans are managing their surgical utilization by relying on a largely downstream intervention. They're using tools like prior authorizations, clinical reviews, and network management strategies. And the core issue with these methods is primarily timing. They're engaging members after a surgery decision is already made. And so they can frequently introduce friction into the member experience. And so, these tools that are leveraged today limit the health plan's ability to influence appropriateness. And the intervention timing is critical because we want to make sure that we're reaching the member before a decision has been made around surgery, when the care decision is still able to be influenced. And as Kathy mentioned, many of these surgical decisions are preference sensitive, and members today are making those decisions with limited information available to them. What we know is early intervention directly reduces unnecessary procedures, as well as improving clinical outcomes. And so a number of the leading plans that we're working with are layering into their existing strategies more upstream efforts to engage the member earlier through a shared decision support process. And so when we think about shared decision support making, we're talking about a process where members are collaborating with their provider to make more informed, potentially less risky care choices based on a more complete and clear understanding of their own risks, benefits, as well as alternative treatment options. And so this is a process that's traditionally owned by the provider and is we believe, a significant missed opportunity for health plans who are uniquely positioned to scale these tools directly to members, ensuring that earlier intervention without having to rely on the providers alone, who very frequently have limited time with their patients. And so we believe the benefits of shared decision making are, number one, improving health literacy. And this is education that members will take with them for the rest of their lives, which, it will reduce unnecessary surgical procedures, which ultimately drives lower utilization in general. And for surgeries that do proceed, surgical complications, issues, and total cost of care.
Mm. Nicola, thanks so much for outlining all of this. And it's really helpful to see some of what you're seeing as these upstream opportunities. I know you've touched on health literacy, and that's a component that I think it would be helpful to go a little bit deeper on. We're talking here about shared decision making with members and using terms like inappropriate intervention or inappropriate surgeries, which I'm sure is a lot to break down at the member level. So Kathy, could you walk us through just a little bit on a deeper level what health literacy in this context looks like and why it's key to managing surgical spend?
Sure. Yeah. So I guess I'd start by defining health literacy as really a person's ability to find, understand, and ultimately use health information to make informed decisions about their care. And about 9 in 10 Americans lack proficient health literacy. So in the context of surgery, as Nicola said, members are often making surgical decisions without full understanding of their diagnosis, without full knowledge of their own personal risks versus benefits, with the surgery and without awareness of what those non-surgical alternatives might be. And that disconnect really is what leads to poor outcomes, ultimately to complications, and just generally unmet expectations for the member, and ultimately higher total cost of care for health plans. So it's really important to address the member health literacy, but also that they learn how to collaborate with their provider. So it's not something they're doing on their own. And together they're making the best decision about care. And as Nicola said, once you build that health literacy muscle in the context of surgery or a surgical decision, that can be applied to other kind of care decisions. So it's has a longer benefit to investing in building that health literacy. And then our digital shared decision support program, My Surgery, is actually designed to do just that and really walks members through a health literacy process. So it starts upstream and it reaches members, as Nicola said, before the surgical decision is made. And you might want to, that slide will give a little bit of a sense of the process. So it really ensures that the member understands their diagnosis to start, and that they're working with the right doctor, and that they're aware of their treatment risks, what the expected outcomes are, and again, what some of the non-surgical alternatives are, so that they can ultimately make an informed decision with their provider. For those members who do proceed with surgery, the program also helps them prepare for surgery and recovery. So there's health literacy related to that as well. And we support ongoing monitoring of symptoms to, ensure that identification of complications, happens as early as possible. So from all of this kind of making a decision about surgery and best preparing for surgery, we see a significant reduction in inappropriate surgeries as members decide to pursue an alternative. And we see optimized surgical outcomes clinically. We also see a lower total cost of care that is measurable in all of our clients' claims data. And I think it would be great for Nicola to talk a little bit about kind of what we're seeing in our data and across our client programs.
Yeah, Kathy, thank you so much. A great overview of the My Surgery platform and kind of how that's supporting members, not just at the decision point about surgery, but what follows. And so, Nicola, I know Kathy just teed you up nicely. I understand that Paradigm conducted a matched cohort study on the My Surgery shared decision support platform with some significant health plan results. So could you touch on those results a little bit and what stood out to you as significant?
Sure. I'll start with talking a little bit about the significance of the difference in differences methodology on its own, and then I would love to get into the results because we're very excited about what they demonstrate. But in short, a difference in difference methodology is important because it essentially proves that the My Surgery program directly caused the results that we're seeing. And so in our industry, of course, there are many vendors that show outcomes, but can't always prove that it was their program that drove those results. And so a difference in differences methodology with statistically significant results answers that key question. Was it the My Surgery program that actually caused the savings and clinical outcomes that we're seeing? And so statistically significant results in particular indicate the true treatment effect of a program. This methodology isolates the impact of external forces, controlling for things like market trends, the introduction of new benefit designs, complementary health programs that these members may also be participating in, as well as member differences like age, gender, and geography. And so it creates a true comparison, looking at program users, which we would call the treatment group, with similar non-users, which we reference as the control group. And so propensity matching is used to ensure that the groups, the treatment and control group, are as similar as possible. And so this difference in differences methodology is considered industry standard for real world outcomes in the evaluation of cost savings and ROI. And so how it was applied for My Surgery is, we certainly started with that propensity matching for our members as a part of the member matching process. And in our study, we matched more than 50,000 program participants across our book of business, which is a substantial number of program participants for this study. And those program participants were compared to a propensity matched control group of non-participants, similar ages, similar health profiles, risk levels, surgical histories, and demographics. And then we measured. As a part of the measuring process, we looked at preference-sensitive surgery outcomes 6 months before and after program completion for both groups. And this allowed us to isolate the treatment effect. So for controlling market trends and other external forces, and looking at those statistically significant differences between the treatment and control groups gives us tremendous confidence that we're seeing the true results of the My Surgery program. And so if we also then want to dive into the cost savings and ROI findings, I will say that in order to lower total cost of care, health plans need to focus on solutions that cut across multiple conditions and populations. And so today, the My Surgery program supports clients in Medicare Advantage, ACA Exchange, and commercial fully insured lines of business. And our results for the study held true across all of these populations. And so what the study proves is that My Surgery drives significant cost savings and ROI across all lines of business and many condition categories. So our total medical cost savings per program participant per year across our full book of business is $5,154, which is truly outstanding, and we're just thrilled with this result. But as you can see, the results are still spectacular for those in commercial populations with more than $4,000 in savings per year, and Medicare populations, it's even better at nearly $6,000 per year. So the savings came from two primary places. The first is the reduction in the inappropriate surgeries that we talked about earlier. My Surgery helps members select more conservative treatment pathways through that, very driving health literacy and member education. We're empowering those members to engage in shared decision-making with their providers, better understanding their surgical risks, recovery outcomes, which allows them to focus on those alternative treatment options. And so across our book of business, we saw, as a result of the study, 116 fewer surgeries per 1,000 program participants. And so then the second primary driver of the savings is a result of post-surgical clinical outcomes and utilization patterns. And so here we are preparing members for their unique procedure and what to expect for recovery. And the result is better outcomes in general again. So as a result of the study, we saw 184 fewer emergency room visits, 884 fewer inpatient stays, 82 fewer sepsis cases, and 23 fewer surgical complications per 1,000 participants. And so here, we think both of these strategies, as a part of a health program, are critical. Many of the strategies we see in market today only focus on surgical avoidance, which leaves a significant untapped opportunity to focus on surgical outcomes, clinical outcomes, and better utilization as a part of the My Surgery program. And so in total, we're thrilled to share that we saw nearly a 7-to-1 ROI through this difference in differences saving study.
Nicola, it's so illuminating to hear about the specific methodology that you used in this cohort study. So I want to thank you for clarifying that. I know it can be challenging to measure upstream approaches and interventions. So appreciate you walking us through that so clearly and seeing these results. Kathy, is there anything that you would add from the ROI or the cost savings perspective?
Yeah, no, we're thrilled to have applied this kind of gold standard methodology that Nicola referenced, and that the results have held steady across the different populations that Nicola mentioned, from Medicare Advantage to commercial, and we see these results delivered time and time again with our clients. So we're feeling really confident and excited about the impact that we can have.
Yeah, fantastic. Well, Nicola, I want to kick it back over to you for a few moments here. Can you unpack the impact that Paradigm's two-pronged approach has had on populations with higher socioeconomic needs? I know this is something that a lot of plans are focused on right now when we're talking about SDOH and bridging health equity gaps and the like. So, wondering if you can elaborate a little bit more on that.
Definitely, I would love to do that. I think you can probably sense my enthusiasm for the results of our study already. But I'm thrilled to share that as a part of the study that we performed, we've seen an impact on populations with higher socioeconomic needs, and our results indicate an additional 30% in total medical cost savings for these populations. Patients in general with lower socioeconomic status have worse surgical outcomes. They have higher mortality, higher readmissions, and a higher number of surgical revisions post first surgical procedure. And so our study found that my surgery has an even greater impact on these lower socioeconomic populations. It improves health equity, it improves health literacy, and we see as a result significant improvements in clinical outcomes. So that additional 30% in medical cost savings equates to $6,660 per program participant per year for members with lower socioeconomic status. The results that we saw across our book of business hold true here as well, where we're seeing a significant reduction in emergency room visits, inpatient days, sepsis cases, and surgical complications. So we couldn't be more proud of these results.
Fantastic, Nicola. Thank you for elaborating a bit more on a really important area of this discussion. Before we open it up to audience questions, Kathy, wanted to bring it back to you just for any final takeaways that you think will be helpful to leave our audience with.
Sure. I think the message that we've shared today is really about ensuring that members get the most appropriate care at the right time while avoiding, unnecessary procedures and spend that can lead to poor outcomes. So I think there are three takeaways. One is that surgical spend is a major driver of total cost of care because it includes the procedure itself, in addition to facility fees, anesthesia, imaging, post-acute care, et cetera. So a single unnecessary spine surgery, for example, can create large downstream costs, and these surgeries span all populations in a healthcare book of business, and it cuts across multiple specialties. I think that's one. Number two, traditional management approaches that Nicola outlined, have limitations. So many plans focusing on prior auth or site of care optimization or network management, those can help manage and reduce costs, but they don't address the issues upstream, as we've talked about quite a bit, to really determine if the surgery is appropriate in the first place. And the third would be, preference-sensitive surgeries represent a really big opportunity because multiple clinically appropriate options generally exist, and the best choice really depends on the member's preferences and goals and understanding of their risks. So really important to empower the member to engage with their provider and ultimately make that decision. So research on our own book of business and data, as you've heard, consistently shows that when patients have the opportunity to receive unbiased shared decision support, surgery rates do decline. And our program has the added benefit of, better preparing members who do proceed with surgery to reduce their own, personal risk of complications and ultimately to optimize their outcomes and be on the lookout for any risks of infection and things like that.
Kathy, thank you so much for those final thoughts. It's been a really insightful conversation with the two of you. And so I just want to thank you for everything you've shared about what you're seeing in the health plan landscape, where Paradigm fits in, where your research fits in, and what you're seeing in terms of results of that more upstream approach. But before we close, let's go ahead and take some audience questions. We have received a few throughout our discussion today, so I'll go ahead and share a few of those. I think we have time for about 3 to 4 of those questions. And Kathy, Nicola, feel free to chime in whenever it feels right. But the first question, pretty straightforward. How do you engage or reach members with this program?
Start, and Kathy, welcome you to chime in. But it's a great question, especially because we talked so much about how important it is to engage members upstream from many of the traditional processes that are in place today. But the My Surgery program takes a population-wide approach. And so there are a number of tools that we use to reach the full population. A number of channels for outreach. We use direct mail. We use a number of digital strategies in outreaching to members. And because the program has been live for several years in market, we have very sophisticated targeted outreach processes where we're able to identify the likelihood of any given members chances of having a preference sensitive surgery. So we're really good at reaching the member at the right time in their healthcare journey and communicating to them in a way that really brings them into the My Surgery program when they need it most. As a part of their experience, we have an embedded incentive. And so we see tremendous program participation and completion as a part of the program structure as well.
Perfect. All right. Well, let's go ahead. Kathy, unless you had any add-ons, we can go ahead to the next question.
No, I think that's great.
Okay. Thanks, Nicola. All right. So next up, we have a question that touches on differentiation. So how does My Surgery differ from other condition management platforms? This audience member already has an MSK solution in place.
Yeah, I mean, maybe we can tag team this one, but I think, we've talked a lot about how My Surgery and shared decision support happens upstream of other solutions. So I think particularly with an MSK solution that's managing a member through physical therapy or, getting to the right provider for their surgery, this can be complementary as well. And I think importantly, MSK is a large category within the preference sensitive surgery area, but it's not the only one. And so I think what differentiates our solution is we're really cutting across all specialties beyond MSK. So it's really an opportunity for health plans not just to look in their condition-specific verticals, if you will, but think about surgical spend as it cuts across multiple specialty areas and also multiple populations. And with the results that Nicola shared, we see remarkably consistent impact across all those populations and specialty areas. So it's really an opportunity to get at surgical spend as opposed to just managing MSK. So I think they can be complementary in that way.
Nicola, any hook-ons to that?
I think it was very, very well said.
Yeah. Great job, Kathy. Thank you so much. Really helpful. Next up, let's talk a little bit about value-based care. I'm sure this is something that's on the minds of more than one audience member here. This person said, we manage our provider network so tightly and they are already in value-based arrangements. So how does your solution add value on top of that?
That is a fantastic question. I will say we support a number of clients in ACA, exchange lines of business, and Medicare Advantage. In those lines of business, we typically see members 25 to 30% of members in tightly controlled value-based care arrangements. And while our solution certainly adds value to all members, the vast majority of the population are working through traditional fee-for-service provider mechanisms. And our solution, of course, adds tremendous value directly to our plan partners for all of the lines of business that we serve, even those that traditionally have a higher proportion of the membership in value-based care arrangements.
Got it. Nicola, thank you so much. Really important question that came through, so I'm glad you had the chance to answer that. I think we have time for one more. All right, this one touches on and care management. So this audience member has other and care management programs that work to manage cost of care within their ecosystem. Is the My Surgery platform, is that redundant to solutions like Second Opinion? And if not, how do you coordinate with them?
Sure, I'll take a stab at that. I think it's similar to the question about MSK in terms of our solution being complementary to second opinion services or prior auth type programs. Because our program is accessed directly by members, as we've talked about, well upstream in their care journey. So it's not creating provider abrasion, which some of these other solutions can do. So it's really about empowering the member, as we've talked about. So if a second opinion or prior auth process is triggered or appropriate, My Surgery can assist in, being upstream, but then triaging the member to those programs at the appropriate time in their care journey. So we can, manage customized messaging, et cetera, to ensure that happens. And our clients have found that to be really valuable, that we can bring the solutions together instead of, having them be siloed. So it provides an opportunity for more of a journey across those different solutions.
Oh, fantastic. Kathy, thank you for rounding us out with the last question that we have time for today from our audience. I just want to take a moment to thank the audience for being so engaged and submitting your questions to Kathy and Nicola. And to the two of you, my wonderful panelists, I just want to thank you for the time that you've carved out of your day to share this information and to be with Becker's and our audience today. Thank you so much.
Thank you, Erica. This has been great. Happy to be here.
And of course, we'd also like to thank the Paradigm team as well for sponsoring the session today. We hope to see everybody at future Becker's webinars very soon. And I hope you have a great rest of your day. Thank you, everyone.